So now we're going to start talking about electrolyte imbalances. Just remember that these can occur really in anyone and can be life-threatening if severe. So again, something to keep in mind is that we do have different electrolytes in different compartments in the body. And so when you think about sodium, potassium are two that we're primarily going to talk about. Sodium is primarily in the extracellular fluid, while potassium is primarily in the intracellular fluids. So, as you have hopefully been reviewing your flashcards, you do want to have an idea of what each of the electrolytes does in the body. We are going to focus in primarily on sodium, potassium, and calcium. However, you do want to be somewhat familiar with the other ones as well. So sodium levels, we usually think this is 136, 135 to 145. Um, and we want to think about sodium as where sodium goes, water follows. And we definitely can have levels of low and high sodium. So we are going to first talk about uh, what happens when there's hyponatremia. And when there's hyponatremia, our cells tend to swell. So this will make more sense as we talk about hypotonic and hypertonic IV fluids. But basically, when there's hyponatremia, it means that there's low levels of sodium in relationship to fluid, which means that there's extra fluid in the extracellular spaces. And so that fluid tries to move into the cells um, to try to balance out that concentration. And so that water moves into the cells and cells swell and can eventually explode when our sodium levels are less than 135. The opposite happens in hypernatremia. So in hypernatremia, there is more fluid inside the cell as outside the cell, or there is the fluid moves from inside the cell to outside of the cell because the concentration of sodium is higher outside the cell than in. So that concentration pulls the fluid from inside the cell to try to equal concentrations on both sides of the cellular membrane. So one of the things that we think about when we think about sodium or hypernatremia is we think about dehydration. And so again, this will make sense more. I'll talk about overhydration, dehydration here a little bit more in a little bit. But please just understand that dehydration has to do with an electrolyte imbalance. So there is a fluid volume deficit in relationship to sodium, meaning that there's now excess sodium. So we need to assess the entire body of this person. They can be in serious danger depending on how severe the dehydration is. Potassium, we're going to talk about. So our normal levels are 3.5 to 5. And just remember the levels that I want you to know, even if they're slightly different, here are the ones that I want that are on your flashcards. So I kind of did, when I made your flashcards, I kind of did a review and picked the most common levels. So please make sure that you're using the ones on your flashcards. Potassium has some control over the intracellular osmolality and volume. It helps with protein synthesis, glucose use and storage, and of course we can have high and low levels. So this is just a way to show how sodium and potassium are regulated. So if there's low levels of sodium or high levels of potassium in the blood, that triggers the adrenal gland to secrete aldosterone. So we increase sodium reabsorption and increase sodium or potassium secretion. And so then potassium is then excreted from the body through the kidneys, and the sodium is reabsorbed into the plasma. So that will help to decrease potassium levels in the plasma and increase sodium levels in the blood. So it's a feedback loop. Another thing that's important to know about potassium are potassium-rich foods. You will need to know these for your exam. And I promise that banana is not going to be a choice. So make sure that you are familiar with the vegetables, the meats, the fruits, the beverages. Calcium is another one. So there's a couple different levels of calcium. The one I want you to know, I promise, is on the flashcard. That's the one that I have on the exam. And calcium absorption does require vitamin D. It is stored in the bones. We've talked about this before. There is a role that certain hormones play, parathyroid and thyrocalcitonin, and then, of course, low and high levels of calcium. So one thing that stands out with calcium, and you'll see this on the charts here coming up, are that patients have certain clinical manifestations, or these are actually called types of tetany, when they have hypocalcemia. So if you pump up a blood pressure cuff, the patient could have, they show a sign where their arm kind of flexes in, or if you tap on their cheek, they kind of wink and make this specific face. So these are called a positive Chopstick sign or positive Troisier sign. And both of those indicate hypocalcemia. So those are ways that if you thought your patient had low calcium levels, but you weren't sure and you wanted to check before requesting a blood draw, then you can use those signs. So calcium, as we talked about with parathyroid hormone, the low levels of calcium in the blood then trigger parathyroid hormone to activate osteoclasts so that calcium and phosphorus are released into the blood. They also trigger the kidney to increase calcium reabsorption, and it also causes the release from parathyroid glands. The intestines increase calcium uptake. So there's lots of different ways in which hypocalcemia and parathyroid hormone work to help regulate calcium levels. Phosphorus, this isn't one that that you necessarily have to memorize right off the bat here, but just have an idea. It's found in the bones. It activates certain vitamins and enzymes. There is a balance between calcium and phosphorus, and people can have low and high levels. Magnesium, same thing. It is important for skeletal muscle contraction and carbohydrate metabolism, works in ATP, which is our energy to do things like our sodium potassium pump. It helps with cell growth and vitamin activation, and people, of course, can have low and high levels. Chloride, usually it's not a chloride imbalance by itself, but it's from other electrolytes that are imbalanced. And if we treat the underlying acid, base, or electrolyte imbalance, the chloride should level back out. So here's where we start to get into the nitty-gritty. This is, again, where I encourage you to make a Venn diagram and put hyponatremia on one side, hypernatremia on the other. Keep all your lows on the left, all of your highs on the right. For each of the electrolytes, I encourage you to make this diagram, or at least sodium, potassium, calcium, okay? And you want to have an idea what are the risk factors? So for sodium, to have low levels of sodium in the blood, we look at GI loss, sweating, diuretics. We look at gain of water. So there could be a bunch of tube feedings that are hypotonic in nature. Somebody's drinking excess amounts of water, or we're giving a D5W IV, and we'll talk about that one a little bit later, or they have a hormone imbalance like SIADH. So what we're seeing here, so if somebody has excess fluid in relationship to sodium, you have to stop and remember, what does that mean for the cells? Well, for the cells, that is meaning that they are swelling. So if somebody has swelling cells, does it make sense that they're going to be having confusion? Some of the things that go into what sodium help regulate. So muscle twitching, cramping, anorexia, nausea, vomiting, a headache, seizures, coma. So a lot of those things have to do with the brain swelling. So laboratory findings are a serum sodium below 135 or an osmolality. I'm not as worried about that one, but definitely you need to know your sodium levels. So we want to make sure we're watching for those clinical manifestations, fluid intake and output, monitor laboratory data, watch closely. So one of the treatments is a hypertonic saline solution, because that's the opposite of what's going on in the body, which would be a hypotonic situation. And hypertonic's only going to be used if the electrolyte imbalance is severe. So please keep that in mind. But if we're administering a hypertonic saline solution, then the patient will be very closely monitored, generally in an ICU setting. Encourage fluid and high sodium intake as allowed. And you do want to know some foods that are high in sodium, and we may need to limit water intake as indicated. So as we continue, we get to hypernatremia. So this is where we've had a loss of water in excess to sodium. So now our sodium levels are high. So somebody may have been, hyperventilating or having a fever, diarrhea, water deprivation, and that would be our loss of water. They also could have a gain of sodium. So maybe we are administering saline solutions or giving hypertonic tube feedings or excessive use of salt. And then there's certain other conditions too, diabetes insipidus or heat stroke. You'll learn about diabetes insipidus in advanced med surg. So what we're looking at here now is primarily a dehydration state. So particularly if we're talking about a loss of water, we're looking at a dehydration state. And so dehydration requires that there be a high sodium level. So the person is going to be just what you would expect if they're dehydrated: thirsty, dry, sticky mucous membranes, a swollen, dry, red tongue. They're going to be weak. If the hypernatremia is severe, then they can have fatigue, restlessness, decreased levels of consciousness, disorientation, convulsions. Again, remember that in this state, the fluid is being pulled out of the cells. So we have cells that are shrinking. And so our sodium levels, you see some level of dehydration above 145. We want to make sure that we're monitoring intake and output. We're watching for those behavioral changes. So if we start getting behavioral changes, that indicates that the electrolyte imbalance is getting more severe. We're watching those sodium levels, encouraging fluids as we can, and monitoring their diet. So they may have to restrict their intake of salt and foods high in sodium. I'm going to go through potassium next. So we have hypokalemia, and So hypokalemia, we think of just a general loss of potassium. So whether that's through gastric suctioning, vomiting, diarrhea, perspiration, medications like diuretics that are potassium wasting, if the person is, has a poor intake, like somebody who has alcoholism or anorexia nervosa, hyperaldosteronism. So some of the things that we look at, and again, you want to keep in mind, what does potassium control? Well, we have muscle weakness, fatigue, anorexia, nausea, vomiting, decreased bowel sounds, and decreased bowel motility, right? Because those muscles and things are not working like they should. Definitely cardiac dysrhythmias, depressed deep tendon reflexes, weak irregular pulses, and we're looking at the potassium levels below 3.5. Arterial blood gases can show alkalosis. We're not getting into that right now. And we're not getting into, we just need to know that there may be changes in the ECG, but we're not getting into the specifics with that yet. So definitely we want to monitor heart rate and rhythm in somebody who has hypokalemia. Another thing that we have to be extremely careful with, and we're going to do some case studies associated with this, is that patients could be receiving digitalis or digoxin, which is something that helps the contractility of the heart. And so if somebody has hypokalemia, it increases their risk of digitalis toxicity. So they may see things like halos and stuff around lights or objects. And this can be a particular risk because a lot of patients who end up with fluid and electrolyte imbalances, it can be because of CHF or congestive heart failure. And those are the patients that are often also likely to be on digitalis. So oral potassium supplementation is often ordered, and it should be given with food or fluids. Sometimes it's given IV, but that has to be given via IV piggyback or through a large bag of fluid. It's never given IV push. It is always diluted by pharmacy, and it has to be given very slowly. It is painful, but it's also potentially deadly if given too fast. We teach the client about potassium-rich foods. As I mentioned, you need to know those, and teach clients how to prevent excessive loss of potassium, like not abusing diuretics and laxatives. Hyperkalemia. So usually when we see an increase in potassium, it's because the body is not getting rid of potassium. It's not excreting potassium because of renal failure or hypoaldosteronism or potassium conserving diuretics. So something like aldactone or spirulactone. Or they could have a high potassium intake. So here we see the opposite. We see gastrointestinal hyperactivity, diarrhea, but we can still see, the apathy, confusion, definitely the same as we saw in hypokalemia. We can see cardiac dysrhythmias, muscle weakness, decreased or absence reflexes, decreased heart rate, irregular pulse. So again, something that would go in the middle of your Venn diagram would be monitoring cardiac status. We also need to watch here that the diuretics and other medications such as glucose and insulin are ordered, so we would administer those. Insulin actually helps the uptake of potassium into the cells where it needs to be instead of in the blood. And then if you're going to order insulin, you have to order glucose, or you're going to cause your patient to suddenly have very low levels of blood sugar. They also are going to hold potassium supplements and hold those potassium conserving diuretics. They may actually give potassium wasting diuretics instead. So other reasons why someone may get hyperkalemia is using those salt substitutes that have a lot of potassium in it, a rapid infusion of potassium, or a potassium shift out of the cells into the plasma. So this can happen with certain infections, um, anything that has a lot of cellular destruction that can happen with, definitely with burns and acidosis. So if somebody has a very large level burn or some sort of crushing injury to their body, that can cause those cells to burst from injury, or like I said, even from infection. And all of that potassium that's supposed to be inside the cells is now in the vasculature. So continuing with the clinical manifestations, paresthesias and numbness in extremities, and then just what we talked about before, higher levels of potassium. And you don't need to know the specifics about the ECGs. We monitor the potassium levels carefully, and as the body tries to readjust and maintain homeostasis, there can be a very quick drop in potassium as that potassium shifts into the cells. So we need to be very careful about that, and we need to have the patient avoid those foods that are high in potassium and salt substitutes. Hypo and hypercalcemia. So we start with hypo again. So if a patient had removal of the parathyroid gland, which is what helps to regulate and release calcium, that could be an issue. Also, there's other conditions: hypoparathyroidism, acute pancreatitis, hyperphosphatemia, thyroid carcinoma, or inadequate intake of vitamin D. So if they have malabsorption, hypomagnesemia, alkalosis, sepsis, alcohol abuse. So some things that we're going to see is numbness and tingling of the extremities and around the mouth, muscle tremors, cramps. And then this is where it can progress into tetany. And so the different signs that you were seeing, the positive Troche's and Chauvet signs, are really kind of part of tetany, which can then lead into convulsions. We also see cardiac dysrhythmias and decreased cardiac output. There can definitely be some cognitive issues: confusion, anxiety, psychosis, hyperactive deep tendon reflexes. Again, know that there's ECG changes, but not necessarily the specifics there. We need to make sure we're monitoring respiratory and cardiovascular status in our patients with hypocalcemia. And we want to make sure that we're protecting a confused patient. We're administering calcium as it's ordered, and we have to carefully monitor a patient who's getting IV calcium. Those patients that are at high risk for osteoporosis need to know that they need a diet rich in calcium and that they need calcium supplements. Remember that the number one way to get calcium into the bones and help prevent or treat osteoporosis is with regular weight-bearing exercise. And some women will do estrogen replacement therapy. Hypercalcemia, so high levels of calcium. We see this from prolonged immobilization. Also, hyperparathyroidism, malignancy of the bone, Paget's disease. Again, we can see things like lethargy, weakness, depressed deep tendon reflexes, bone pain. It hurts. That calcium is coming out of the bones. Anorexia, nausea, vomiting, constipation, polyuria or hypocalciuria, where we see excess levels of calcium in the urine. Flank pain because of renal calculi or urinary calculi. So remember, that's kidney stones, because in hypercalcemia, there's extra calcium in the blood, and that is getting deposited places throughout the body, and particularly in the kidneys when the kidneys is trying to filter that blood out. Dysrhythmias, possible heart blocks. There's the levels there, as well as remembering there's ECG changes. So we definitely, our interventions, we want that person to move to exercise that will help put that calcium back into the bones where it should be. Plenty of fluids to help dilute the urine. We want them to limit the intake of food and fluid high in calcium. We want fiber to help with constipation. Always safety for anybody who is confused, and watch for fractures for those with long-term hypercalcemia. And we can encourage an acid ash diet, things like prunes or cranberry juice, to try to help the deposits of calcium salts in the urine. I'm not going to go through hypo and hypermagnesemia. They are on here. You can review them um, on your own, but like I said, they're not as main of a focus for us. And just keep in mind that overall, our older adults are at risk for most electrolyte imbalances. They have less total body water and are more at risk for fluid imbalances as well. And they are more likely to be taking medications in which these imbalances can happen very rapidly.